It all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the CEO and founder of the Global Liver Institute, and I have the honor and privilege of being your host for this episode of GLI Live. Today, we are continuing our spotlight on minority health and health equity. And to help me with this very important topic is Veronica Sandoval. Dr. Sandoval is Principal Patient Inclusion and Health Equity at Genentech, one of our favorite partners. And she is going to share with us some of the work and the approach that Genentech takes to advancing health equity. We're really excited to hear some of the models and activities that they've been creating throughout the organization. Dr. Sandoval, welcome.
Thank you, Donna, for that very kind welcome. And I'm super excited to be here and just share the journey that Genentech has taken in truly advancing health equity and inclusive research within our organization.
Excellent. Excellent. So tell us about your career path. How did you come to Genentech? How did you come to do clinical trial diversity and health equity work?
Yes. So I've actually, been at Genentech for now 4 years. But I started my journey, I always say, I'm not going to take you all the way back, but sure tell you, that my love for research started in graduate school and even undergraduate. So I did research as an undergraduate at UC Berkeley, then have a PhD in neuropharmacology from the University of Utah. And truly that's where an area of understanding, as trained as a neuroscientist, understanding Parkinson's disease, and also leaning a little bit into drug addiction and trying to figure out what's going on in the brain. And, in trying to make that bridge between the science that it happens at the bench to taking medications all the way to patients' hands. Right. And that's where my excitement started. As a scientist, I'm like, what else can I do to really bridge that gap between scientists and patients? And being part of U.S. medical affairs here at Genentech, and supporting clinical programs like an autism and then respiratory and asthma, I had the opportunity and an honor to work with a lot of our key opinion leaders in various areas and even understand from them, what are your patients needing? What do we need? What do we need in clinical trials? And one of the struggles that I had was when I had those minority doctors that were in the community that wanted to do research, that were eager to do the research on the patients, but lacked the experience of doing the research. Right? And I, as a medical science liaison, I felt frustrated. I'm like, what else can I do? And then this opportunity at the Chief Diversity Office, just landed on my lap, and I was, sold because, my boss, Dr. Sapna McManus and Quita Smith, both of us said, this is what the Chief Diversity Office does. We advance inclusive research at an enterprise level and advancing even our health equity. Are you interested? Can you join us? I'm like, yes, sign me up. I want to know, I want to help those patients and those doctors. Because in honesty, Donna, when we have those clinical trials, if we have doctors that look like the patients, we have even the staff that looks like those patients, that's when we truly are going to start, dismantling some of those barriers. And I'm just super excited that I get paid to do this job. I get paid to think about ways that we could truly advance these initiatives. So that's what excites me, and I'm super excited, just to share, some of those initiatives that we've been working on here at Genentech.
We're excited that there's someone so passionate and clearly so well qualified to be doing this work, is given the freedom and support within the company to do this type of work. It's wonderful to hear that Genentech has created not just one position but an office, so that it has sort of the whole of the company, the enterprise-wide endorsement for doing this work. I have found that unless this is built into the business process for a corporation, it's just ends up sort of window dressing. It's just something sort of nice to do instead of something really essential and core to how people do their work.
I couldn't agree with you more, Donna. That's what, Quita Highsmith, as being the Chief Diversity Officer at Genentech, she is a powerhouse, right?
She's no joke.
No, she's not, right? She drives us, and all of us at the Chief Diversity Office, from my team and the patient inclusion and health equity team that support that advancing inclusive research, right? We're one of the 3 pillars at Genentech. We have the fostering belonging that looks inside of walls. How do we advance our employees? And then we also, how do we transform society and patients and the partners that we're, partnering with to advance these initiatives? Every pillar, right? Quita is our anchor, right? And she really helps us. And as you say, she gives us that freedom to really bring all of ourselves and say, okay, this is how we're going to change one step at a time, because it takes time, but we're getting there.
But patients are eager for it. We've been waiting a long time. Last night I was at the National Minority Equality Forum meeting. It was the 17th time I've been attending. I think they're almost on their 20th year. And so we've gone through minority health and multicultural health and health disparities and social determinants of health. And now we're in health equity. And so what will be different this time? What will you put into place that will help make clinical research and enterprise truly more inclusive, so that patients, and as you put it out, minority physicians who are connected to those patients have a real opportunity to participate?
And that is something that at Genentech we were taking, very seriously. And we even made this public. If you go to gene.com, we made our 2025 commitments public. And within our advancing inclusive research and health equity, we have made the commitment that by 2025, all of our molecule teams will have embedded diversity and inclusion plans in the research that we do. I'm also here at the National Minority Equality Forum. Maybe we missed each other, right? And we crossed our paths.
Back home to do this.
And, but that at that forum, at NMQF, what we were talking about is it's going to take the support and partnerships across different players, industry, healthcare providers, policy legislators, patients themselves, and patient advocacy groups, right? And by, in bringing it back to this 2025 commitment that we made, in really saying, let's start earlier in the development pipeline, right? Because if we start thinking of diversity once a drug has been approved by the FDA, I think we've missed the boat. It's too late.
Absolutely. It's too late. And it seems like you are very much ahead of what FDA has recently called for in their new guidance, that builds on old, but the new and improved diversity plans to increase participation of minority and underrepresented populations in clinical trials. And it seems like you were ready for that, and well positioned to be able to do that work. And so how has what FDA has asked for aligned with the things that you're doing and planning to doing in these 25 commitments?
We were actually excited. I think our Chief Diversity Office was very excited to see those guidelines, because in all honesty, we need them, right? We need when it comes from a regulatory agency, then, industry, and this includes Genentech, right? We can no longer say diversity is a nice to have. It's a must have.
Right.
Our patients need this, right? We need to make sure that we are inclusive in our research, even, and I'll use the triple negative breast cancer as an example, right? Because everyone, I think that's being elevated in the differences of triple negative breast cancer in Black women, and how Black women are actually, higher at risk for breast cancer at a younger age of 30 versus the guidelines to say, let's start mammograms at the age of 40.
Right.
So when we have those conversations and we start saying this is important, not only because of the regulatory agency requirements, but truly because as an industry, we want to make that difference. And we want to take it back to our scientists who are thinking about, what is the next target? But not only asking what is the next target of a particular cancer, but have them really think about what are those disparities?
Right.
What are the different areas and what is the science and the epidemiology that we have and the prevalence in the different races, age, groups, not beyond, encompassing of a true diverse plan. Let's start there, the conversations. And then let's start asking, okay, so if that's the case, what can we target? And are there going to be differences? Because that's truly going to revolutionize even the way that we're doing the science at the bench. And then how that translates to more innovative medications that are truly going to be effective in treating the diseases that we want to treat.
It does. A question that I am increasingly asking and being asked is, what does diversity mean from a global standpoint? If you're doing global trials, then how do those demographics differ? How do your plans to include patients differ?
And that's a great question, Donna, because as a global company, right? How do you speak to your global colleagues when you're talking about diversity and inclusion? When, and let's be frank, when you're talking to ex-USA and you're going to, especially those European countries, when you're talking about race ancestry, they always think that's a US problem.
Right.
We don't have that problem in our countries. But in all honesty, I just don't think that that's true. I'm like, are you hiding your head in the sand? Because disparities exist, right? And it's not the fact that it's we're targeting to race, to a minority group, but I think we should shift that and say, what are those underserved communities in your countries? Because when we ask, well, fine, if you don't have, a African American, Black community, Latino community in your countries, do you have underserved, people in your country? The answer is yes. We have underserved patients. So if we
they might be Arab,
yes.
They might be African immigrants, they might be a lot of different ethnicities, or it could be sexual orientation and gender identity and other things that are do make a difference in how people receive care. And even just gender in trials. I would be remiss, having worked with Phyllis Greenberger for so long, not to mention that the inclusion of women in trials is still, in some places, not everything that we would want it to be. So there are lots of different types of diversity, and so you need to sort of tailor your strategies to the appropriate types of diversity for the disease, and for the country or community in which you're recruiting.
Absolutely. I couldn't have said it better, Donna.
You can say this is an area that I love very, very much as well. And we certainly have enjoyed talking and brainstorming with your liver cancer teams about how to create more inclusive community engagement on liver cancer in both education and research, and the training of our community ambassadors to help with that process. What you have a august research board of advisors on this, and so I wonder if we can get some insights into the insights that they've given you in terms of problems that can be solved maybe immediately, and those that maybe need medium term, and then some long term aspirations for the work.
Yes, and I love that you're bringing the external Council for Inclusive Research that we formed, and actually we formed this council back in 2018,
Right.
so they've been with us
Right.
for some time. And, in this council, just so the public, and attendees who are listening, is composed of different thought leaders, from academic researchers, patient advocates, the range of expertise. We have oncologists, ophthalmologists, general practitioners, and a neurologist. And what all of them bring in is, even though that their therapeutic area of expertise is different, what makes it unique is that all of them have done and are champions in driving inclusive research.
Right.
And from their practices, in their community outreach, to the clinical trials that they conduct. And they've really have helped us in evaluating and making changes to our clinical trial process, and have helped us make a more patient-centric approach as to how we approach our clinical trial development program. And, and one of the things that this external counsel, and that if you ask me, what is one of the proudest moments, I could tell you from the time that we brought this group together, it was always in the conversation. So what else can we do? How can we get all of the insights that we discuss in this external council and share them with the world, right? So we actually, it took us some time, but we published, this year in January, we published all of the learnings from the external council in the ethnicity and disease journal, where we talk about the strategies for improving diversity. And the team, or the council, did a fantastic job in forming recommendations for future clinical trials.
Yes.
Right. And this is based on the efforts at Genentech, their own personal efforts that they've seen. And they actually, they go through, and in the publication, we talk about 3 buckets. The system level, where is addressing the barriers that are currently prevent participation. And that, and that requires actual investment, right, in healthcare infrastructure and policy reforms to build that trust that is needed. Then we move into the second bucket, which is patient level. And, one of the things that even at the NMQF meeting that the topic and theme was that community, building community and trust, right? And that's another bucket that we talk about in this publication, is that there has to be a way that the industry overcomes this distrust at the patients, right? How do we actually start repairing that trust? How do we increase awareness of the work that we're doing? How do we even help decrease those financial barriers that contribute to the fact that patients of color do not participate in clinical research? So there's some ideas in that publication. And the last bucket is at the study level, where they talk about this being a multi-level strategy that is across all industry, right? That we need to figure out how to run better clinical development programs, lower the costs, expand access and enhance patient participation from minority communities.
Mm-hmm.
But, in this publication, I could spend the entire time talking about it. But, if the attendees like, I could share with you the link so you could share it later.
Absolutely. Absolutely.
I think it's a good read. It's a fast read, but it really
Mm-hmm.
gives you those highlights, which is needed, right? Like, where do we start? What is Genentech doing with the external counsel? But at least that gives you a framework of the different buckets that we spend time talking about.
Yeah. I've loved reading it, and as somebody who has been working in this area, I built a multicultural vision for a clinical trial recruitment firm. I was so excited to see those recommendations, and some of them were things I hadn't thought of before, and that's a good thing. But it also just put so much of the best practices and the best thinking in one place, and at a place that can make it happen, that you can catalyze actions even if you can't do it in yourself, through the partnerships that you've talked about. You can really help advance that in a very significant way. One question that I had, coming through, hopefully we're coming through, but at least at this stage in the pandemic, decentralized trials or hybrid trials, or just trials that come closer to the people instead of people having to go closer to the trials. Do you see that as something that will continue after the pandemic?
Absolutely. That is an area that even at Genentech, we're investing, and we are trying to understand, how do we take the trials to where the patients live, that decentralized clinical trial concept. And we are actually partnering with the VA in Durham, and trying to figure out, those patients that live in those rural areas,
Right.
and when you made that reference, right, it may take them, travel time 2-3 hours to get to that VA that is centralized, that actually has, all of the expertise. But with COVID, we learned we could do telemedicine very well. There are, we could actually even use the facilities around the patient that, in most of the clinical trials, Donna, as you know, do not require patients to go to the clinical trial site.
Right.
Some of those assessments can truly be conducted via telemedicine. You could have a nurse that comes to the patient's home. There's a lot of different ways, right? So we're exploring that through this study that we're conducting with the VA, and trying to figure out, even how can we leverage the digital technology that we have? Is it going to be successful? And then trying to take some of those learnings and start putting them in our oncology studies, to try and test and do some experimental outcomes, and really gather that data that we need, because everything is data driven.
Yes.
Right. So we have the data, we could show that it's sustainable and it works. I think that is truly going to be the next generation, and the version 2.0 as to how industry will start conducting clinical trials.
I think it's listening to you, it seems like it's both high touch, coming closer to people, sending nurses to homes and things, but very high tech. Capturing the data in a variety of new digital tools, being able to analyze it. And so I think that's what's exciting to me. It's both better science, but in a way more human science as well.
Yes, but that is, I think, also, Donna, where we're going to need policy, right? Because even in those rural areas, the internet access is an issue, right? And Genentech cannot fix that. Industry cannot fix that,
but
right?
The Congress and approving monies for broadband can, yes.
And that's where we're going. And that's why I said at the beginning, this is going to take partnerships. It's going to take all of us in our society, from government, industry, patients, healthcare providers, to really say, this is truly what we need. And I think, I honestly think that, with Cancer Moonshot being revived, I'm hopeful that some of these issues would be brought to the table, with with the infrastructure bills that have been passed, that some of these issues can be and should be fixed, to truly address those clinical disparities that our patients, regardless of race, color, everyone is facing in our society.
One of our great partners in the Patient Advocate Foundation has been reorganizing their financial assistance towards social vulnerability indexes or indices, and I think that is so smart, and they're so smart, but I really think that does get to address who's really most in need and what factors. It could be race, ethnicity, low socioeconomic, income. You could actually have a high income, but the medical costs or are so high that it actually makes you quite socially vulnerable. Or your income is high, but you are taking care of a lot of people. And so really looking at a zip code level, looking at the resources in those areas, the resources of the individuals, and then being able to support them in their healthcare journey and in their journey participating in clinical trials from a concept of social vulnerability, I think is a really smart way of looking at this and making sure that the people who need help the most get it.
Absolutely, right. And you even touched on some of the social determinants of health, right?
Yeah.
And I think we always forget that really makes an impact on the health outcomes of our patients, right? And I always say, I'm a patient, my family is they're patients. So that's even more important for me, working at Genentech, being part of the Chief Diversity Office. It's like, how can we make this journey of our patients, because that includes my family,
Right.
better. And if we could improve that, we're going to improve the patient outcomes for everyone and get closer to that equitable healthcare that all of us want in this country.
That's true. I can't think of a better way to say it. So I'll simply end on that note and say thank you so much, Dr. Sandoval, for joining us today.
My pleasure. Thank you for having me.
Absolutely.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.